Which abnormality on the 24-hour ambulatory ECG is clinically most important? Atrial premature beats, profound sleep-associated bradycardia, supraventricular tachycardia, transient Mobitz type 1 AV block, ventricular premature beats. A 37-year-old woman presented with a history of intermittent lightheadedness. Examination was normal. ECG was normal. 24-hour ambulatory ECG tracing shows atrial and ventricular premature beats, nocturnal bradycardia and Mobitz type 1 atrioventricular block, and supraventricular tachycardia. Which abnormality on the 24-hour ambulatory ECG is clinically most important?
This patient has presented with a history of intermittent lightheadedness. Examination was normal, coupled with normal ECG findings. And 24-hour ambulatory ECG tracing is showing the evidence of atrial and ventricular premature beats, nocturnal bradycardia, Mobitz type 1 AV block, and supraventricular tachycardia. History of intermittent lightheadedness is the most reliable explanation for the supraventricular tachycardia (SVT), especially with the normal ECG findings. Regular narrow complex tachycardia is the cardinal ECG findings of supraventricular tachycardia (SVT). With the absence of P-waves, the most likely cause of SVT is the AV-NRT, and AV-NRT usually occurs secondary to re-entry circuit, causing the premature ventricular contraction (PVC). Patient with SVT usually presents with the ECG features of regular narrow complex tachycardia. Retrograde P-wave is visible in continuity with the QRS complex, appearing as a pseudo R-wave in lead V1 or a pseudo S-wave in the inferior leads. With the features of intermittent lightheadedness in a patient with SVT, we need to go for the management. The first line management of SVT is vagal maneuvers, either Valsalva maneuver or carotid sinus massage. According to the Resuscitation Council guidelines, a regular narrow complex tachycardia in the absence of adverse features like shock, syncope, myocardial ischemia, or heart failure should be treated initially with the vagal maneuvers. And whenever there are features of adverse sign, meaning patient presenting with hemodynamic instability, we should immediately go for the DC cardioversion. So vagal maneuver is the first line choice of management provided that the patient is hemodynamically stable, meaning absence of the adverse sign. And whenever there is features of hemodynamic compromisation, meaning patient coming up with the adverse features. Adverse features can be remembered as SSC: shock, syncope, chest pain or myocardial ischemia, and cardiac failure. So whenever there is hemodynamic compromisation or whenever there is adverse features, we should immediately go for the electrical cardioversion. Patient with SVT who are hemodynamically stable and who don't respond to vagal maneuvers, the next step is treating with adenosine. So if the patient is hemodynamically stable and unresponsive to vagal maneuvers, the next step of management should be IV adenosine. Rapid IV bolus of 6 mg. If unsuccessful, give 12 mg. If unsuccessful, give further 18 mg. So 6, 12, 18. This is the latest guideline. IV adenosine is also contraindicated in asthmatic patients due to the features of bronchospasm. So in a patient with asthma, we should go for the verapamil, rate-limiting calcium channel blockers. And for the prophylactic management of SVT, first line choice of treatment is beta blocker followed by the radiofrequency ablation. In this scenario, considering the patient is only having the intermittent lightheadedness, so the most appropriate management protocol in this SVT would be the prophylactic management, starting with beta blockers followed by the radiofrequency ablation. Ventricular premature beats, also known as premature ventricular contraction (PVC), and atrial premature beats, also known as premature atrial contraction (PACS). Both PVC and PACS are the benign condition and can be fully eliminated by lifestyle modification, cessation of caffeine and tobacco, And intervention is only required if the patient comes up with the features of arrhythmia or cardiomyopathy. ECG is showing no features of arrhythmia and no features of cardiomyopathy. So no intervention is required both in PVC and PACS in this patient. Profound sleep associated bradycardia may be a common phenomenon in many individuals, and intervention is only required if the patient comes up with significant bradycardia, heart rate less than 40 beats per minute. ECG is excluding the significant bradycardia, so no intervention is likely to be required. Transient Mobis type 1 AV block, also known as the Wenckebach phenomenon. Intermittent lightheadedness may be a presentation of Wenckebach phenomenon, but intervention is only required when the patient comes up with the typical ECG changes. Typical ECG findings in Mobis type 1, also known as Wenckebach phenomenon, would be progressive prolongation of the peer interval until a drop to it occurs. This is the ECG of a patient showing the Wenckebach phenomenon. There is progressive lengthening of the peer interval culminating in a drop beat. Transient Mobis type 1 AV block with normal ECG findings, intervention is unlikely to be required. So finally, considering the isolated history of intermittent lightheadedness on 24-hour ambulatory ECG, the most important clinical abnormality would be the supraventricular tachycardia, SVT. Supraventricular tachycardia is the best answer. It would provide a plausible explanation for the patient's symptoms and may merit specific treatment, either drugs or ablation. So first line would be pharmacological drugs with beta blockers, followed by the radiofrequency ablation.